Bismillahirrahmanirrahim. Quote of the day and the best of people are those who are the most beneficial to the people. Today, the topic of presentation is association and causation. I'm Dr. Rabbia Iqbal, PGR Community Medicine, and presenting under the supervision of Professor Dr. Saira Afzal, IPH Lahore. Learning objectives. At the end of this presentation, participants will be able to describe a frequent sequence of study design used to address question of ecology in human population, differentiate between real and spurious association in observational study, define the concept of necessary and sufficient in the contents of causal relationship, present guideline regarding association, describe how the association causation guideline have been modified by the U.S. Public Health Service and Preventive Services Task Force. A two-step process in epidemiology. Step one, is there any association? Determine whether an exposure or a characteristic is correlated with the disease outcome. Step two is the association causal. Evaluate whether the observed association reflects a true cause and effect relationship. If association is found in step one, we proceed to step two to determine its nature. Next is the approaches to study disease etiology, animal study, toxicology, control over exposure dose, genetic factor, minimal loss to the follow-up. So the limitation of this is problem of extrapolating across species cannot reflect all human diseases. In vitro studies useful for mechanistic understanding at the cellular level. Artificial system difficult to extrapolate into intact human organism. Human population studies direct evidence in the species to open interest most relevant for policies. So limitation cannot ethically randomize human to harmful exposure dependent on observational data. This is a sequence of studies in a human population. First, clinical observation, bedside observation by the clinician or trace approaches. For example, lung cancer patient almost all had smoking history. Available data analysis of a routine available data or the existing data, for example, vital statistics, hospital record, disease history. Case control studies, comparison of the exposure between case and the control, for example, comparing smoking history of the lung cancer versus non-smoking patient. Cohort study followed exposed versus unexposed group prospectively, for example, smoker versus non-smoker followed for the lung cancer. Next is a randomized trial, which is the gold standard, rarely used for the harmful exposure, mainly for beneficial intervention. For example, smoking cessation trial in the pregnant woman. Next is the unplanned or the natural experiment. Epidemiology capitalize on group exposed for a non-study process, occupational, cohort, environmental, and disaster, etc. For example, in Bhopal, India, in 1984, an event occurred in which poisonous gas leaked at the Union Carbide pesticide plant. So the study was conducted between the comparison of the exposed resident versus the unexposed population for the adverse health effect. Next is the Hiroshima and Nagasaki, Japan, 1945, atomic bomb radiation exposure by the US force. So the study was conducted between the exposed survivor compared to the Tokyo versus non-exposed resident for cancer and other disease. So next is the type of association. When we observe an association, the first question is this real association or a spurious? So the real is the true association. The association exists in the population not due to chance or bias. So it can either be casual or non-casual. Casual association is due to exposure directly or indirectly cause disease. Non-casual are the confounding. Both exposure and the disease are associated with the third factor, factor X. Spurious association, a false association, appear to exist when, but does not truly reflect the relationship in the population. So it arises from the selection bias, non-representative sampling of the control, information bias, recall, or the measurement error. So there is a chance of random variation in the small group, small sample. Next is the type of association, which is casual, and the confounding association. Casual, in which the exposure took place and result in disease as the outcome. The exposure directly induced the disease. Observed association is equal to true casual relationship. Second is the due to confounding, in which exposure disease result due to the and also the third factor present, which is co-founder. Exposure and the disease appear associated only because both are linked to the common third factor. This is confounding. The classical example of this is McMahon study. McMahon study observed that the coffee consumption was associated with increased risk of pancreatic cancer, but cigarette smoking are also known as associated factor with pancreatic cancer, and drinking coffee, cigarette smoking are closely associated. Few smokers at that time did not drink coffee. So the critical question of this study was casual coffee drinking result directly cause pancreatic cancer, or confounding coffee is associated with smoking and smoking is the cause of pancreatic cancer. So, distinguishing casual from the confounding association is a crucial. If the relationship is casual, promoting coffee abstinence could reduce the pancreatic cancer risk. If confounding, which is by smoking, coffee restriction would be ineffective. Next is in which maternal smoking shifts the entire birth weight distribution curve to the left. So the great debate in the casual view, smoking directly causes reduced fetal growth. Dose response exists. The more a woman smokes, the lower the birth weight. RCT of the smoking cessation in the pregnancy woman confirmed this. And the confounding view of this is smoker differ actually from the non-smoking in many behavior or biological way. Low birth weight due to other characteristic of smokers. Non-smoker itself, yeah, so women who smoked before pregnancy but not during had similar low birth weight rate to non-smokers. Next is the direct and the indirect causes of the disease. Direct causation, in which factor or the exposure result in disease. The factor directly cause disease without any intermediate step. For example, cyanide poisoning result in cell death. Indirect causation, in which factor result step one, step two, and then disease occur. So factor act through the intermediate steps. For example, smoking, carcinogens result in DNA damage and cause lung cancer. In human biology, intermediate steps are virtually always present. So, next is the types of causal relationship. Type 1 is necessary and sufficient. Type 2 is necessary but not sufficient. Type 3 is sufficient but necessary. Type 4 is sufficient, neither sufficient nor necessary. So that type 1, which is necessary and sufficient, disease never dwell without the factor, and disease always dwell when the factor is present. Rarely occur. For example, rabies virus nearly 100% fatal if untreated. Type 2, necessary but not sufficient. Factor must be present but alone cannot cause disease. Multiple co-factor required often in a sequence. For example, tuberculosis bacillus is a necessary for TB, but other factors like immune status, malnutrition also needed. Third is the sufficient but not necessary. Factor alone can cause disease, but other independent factor can also cause it. For example, radiation or benzene can each independently cause leukemia. Now, the fourth one is neither sufficient nor necessary. Most complex model constellation of risk factor needed. Each factor contribute, but it neither required or not alone sufficient. For example, chronic heart disease, smoking, diabetes, low HDL, hypertension, physical inactivity, neither a cluster nor a single factor. Next is the Rothman sufficient cause model. A sufficient cause is a constellation of component causes that together are sufficient to produce disease. So the sufficient cause one, diabetes, high LDL, genetic susceptibility, and sufficient cause two, smoking, low LDL, arterial hypertension, physical inactivity, result in atherosclerotic disease. Each component cause is neither sufficient nor necessary, but itself individual risk factors are components of a sufficient cause cluster. This is why the most individual risk factors for chronic disease are neither sufficient nor necessary. Next is evidence for a causal relationship that calls Henle postule in 1840 to 1880. According to Coase postule for the infectious diseases, the organism is always found with the disease. The organism is not found with any other disease. The organism, when is isolated from the disease host culture through a several generation, produce the disease in experimental environment. So the limitation of this is non-infection diseases like cancer, chronic heart disease become more prominent in 20th century. No organism could be isolated. The U.S. Surgeon General appointed an expert committee to develop new guidelines for causation applicable to complex multifactorial diseases. So, as guidelines for the judging causation, first one is temporal relationship. Second is strength of association. Third, dose response relationship. Four, replication of the finding. Five, biological possibility. Six is consider for alternative explanation. Cessation of exposure. Eight one is the consistency with other knowledge. And nine is specificity of the association. The first one is a temporal relationship, which is defined as exposure to the factor must precede the development of the disease. This is the only absolute requirement for causation. Order matters. If the disease appeared before the alleged exposure, the exposure cannot be casual. Prospective cohort study best established temporal order. Length of the interval, the time interval between the exposure and the disease of development is critical. For example, asbestos result in lung cancer later period of 15 to 20 years. If cancer appeared after 3 years of asbestos exposure, it was likely not caused by it. London smoke exposure example, in December 1952, rise in airborne particulate concentration followed by a rise in daily mortality, then decline in particle followed by decline in death. Powerful temporal evidence for an air population causation. The temporal relationship are easier to establish in a prospective cohort study than case control or the retrospective cohort study. Next is strength of association measured by relative risk or the odd ratio. The stronger the association, the more likely it is in casual, less likely to be explained by the confounding other bias. Dose response relationship, as the dose of exposure increase, the risk of disease also increase. Strong evidence for causation through, though absence of dose response does not rule out the causation. For example, bronchogenic carcinoma by the smoking. If there is no smoking, so no carcinogenic present, 50% chance of half packing per day, 59% chance 1.5 pack per day, and so on. Next is replication of the finding. The relationship should not be found consistently across a different study design, population, and investigator. If the association is observed, we expect it across population subgroup unless there is a clear reason to expect different result. For example, the smoking lung cancer link was observed in multiple countries in both men and women in prospective and the retrospective studies, and across a different time period, massively strengthen the causal interference. Next is the biological possibility. There should be a coherence with the current body of biological knowledge, a mechanistic understanding of how the exposure could cause a disease. However, epidemiological findings sometimes precede biological knowledge. For example, observation and on rubella and congenital cataract precede knowledge of tetragenic virus. High oxygen lentil fibroplasia was identified epidemiologically before the mechanism was understood. Next is the consideration of alternative explanation. Before concluding the causality, alternative explanation must be systematically considered and ruled out. The extent to which investigators have identified and controlled for confounder strength causal interference. For example, in smoking low birth weight debate, the association was confounded by other characteristics of smokers. The subsequent randomized sensitization trial rule out the alternative explanation. Next is the cessation of exposure. If the factor is casual, removing the exposure should reduce the disease risk. Decline in disease following removal of the exposure strongly support causation. For example, lung cancer death rate fell in men who stopped smoking. Eosinophilia and myalgia syndrome in FDA recalled L-tryptophan dramatic fall in eosinophil myalgia syndrome cases. Some diseases are irreversibly initiated. For example, emphysema progression is slowed, not reversed by the cessation. Next is the consistency with other knowledge. The epidemiological findings should be consistent with other available data, biological data, clinical observation, and data from other epidemiological study. Inconsistency demand explanation. For example, parallel trend between cigarette consumption and lung cancer in both men and women show the same pattern consistent with the causal hypothesis for smoking and the lung cancer. A specificity of the association, a specific exposure cause one specific disease. This is the weakest guideline may need to be removed. Cigarette smoking fails specificity. It causes lung cancer, pancreatic cancer, bladder cancer, chronic heart disease, emphysema, and many more conditions. So example of specificity of the association is why does not lack of specificity negate causation? A single agent can affect multiple tissue. Cigarette are the mixture of thousands of compounds result in multiple effect. Absence of specificity does not rule out the causation. This is a case study in which assessment of evidence suggesting H. pylori as a causative agent of duodenal ulcer. Marshall and Warren, 1984, discovered small curved bacteria H. pylori in the stomach of patient with a gastritis and peptic ulcer. Previously, peptic ulcer was attributed to stress, acid, and lifestyle. However, H. pylori caused greater than 90% of the duodenal ulcer and up to 80% of gastric ulcer. So the temporal part is H. pylori clearly linked to the gastritis, and 11% of the go to develop duodenal ulcer over 10 years. Strength H. pylori found in greater than 90% of the duodenal ulcer patient, partly absent in a tribe with no duodenal ulcer. Dose response density of H. pylori per scale of the gastric mucosa higher in ulcer patient. Replication observed rapidly replicated internationally. Biological possibility, H. pylori has binding site on the antral cell, induce inflammation and weaken the mucosal defense. Cessation, eradication of H. pylori heals ulcer at the same rate as H2 blocker long-term recurrence. 0% versus 60 to 80 relapse without eradication. Next is the US Preventive Service Task Force. Application of the casual guideline to screening and preventive policy. These are the A grade, high certainty of substantial net benefit, offer or provide the services. B, the high certainty of moderate benefit or moderate certainty of moderate to substantial benefit, offer or provide the service. C, the moderate certainty of small benefit, offer selectively, individual patient consider apply. Grade D, moderate to or high certainty that service has no benefit or harm, overweigh benefit. Discourage the use of this service. Grade I, insufficient evidence to assess balance of benefit and harm. Ensure the patient understand the uncertainty. These are the 8 key questions used by the task force for any screening recommendation. First one is, does screening for X reduce the morbidity or mortality? Can a group at a high risk for X be identified on a clinical ground? Are accurate, sensitivity, or specificity screening tests available? Treatment available that make a difference in the intermediate outcome when disease is caught early? Are the treatments available that make a difference in the morbidity and mortality when the disease is caught by the screening? How strong is the association between intermediate outcome and the patient outcome? What are the harms of screening tests and what are the harms of treatment? So next we come to the MCQs. Which of the following is the only absolute essential criteria for cessation? Causation, A, biological possibility, B, strength of association, C, temporal relationship, D, dose response relationship, E, specificity of the association.
C.
Yes, C is the right option. MCQ number 2, an observed association between coffee drinking and pancreatic cancer was later suspected due to smoking. This is an example of A, information bias, B, selection bias, C, affective modification, D, confounding, E, random variation.
D.
Yes, D is the right
C.
option. D is the right option. Confounding. MCQ number 3, and a factor that must be present for a disease to occur is called A, component cause, B, sufficient cause, C, necessary cause, D, indirect cause, E, spurious factor. So C is the right option. MCQ number 4, which study design is the best for establishing temporal relationship? A, cross-sectional study, B, ecological study, C, case series, D, prospective cohort study, E, case control study.
D.
Yes, D is the right option. MCQ number 5, in Ruthman sufficient cause model, chronic disease usually result from A, single necessary agent, B, multiple component causes, C, pure genetic abnormalities, D, random biological variation, E, an unknown infection organism. A. B is the right option, multiple component causes. MCQ number 6, which Bradford Hill criteria becomes stronger when increasing exposure, increase disease risk. A, consistency, B, specificity, C, analogy, D, dose response relationship, E, temporality.
B.
Yes, is the option. 7, a spurious association may rise because of all except A, chance, B, bias, C, confounding, D, random error, E, true biological effect.
E.
Yes, E is the right. Yes, E is the right option. MCQ number 8, in epidemiology, confounding occur when A, exposure directly causes disease, B, selection procedure distorted finding, C, both exposure and the disease are linked to another factor, D, information is reflected incorrectly, E, randomization is inappropriate done.
C.
Yes, C is the right option. MCQ number 9, a researcher finds a smoker have a relative risk of 20 for lung cancer compared to non-smoker. This primarily support which criteria? A, temporality, B, strength of association, C, consistency, D, possibility, E, specificity.
B.
Yes, B is the right option. MCQ number 10, which of the following is the best example of natural experiment? A, randomized vaccine trial, B, laboratory animal experiment, C, atomic bomb survivor study, D, hospital case series, E, cross-sectional survey.
C.
Yes, C is the right option. So this is the answer key. This is the YouTube channel where the presentation will be uploaded. Thank you.
थैंक यू वेरी मच रबिया, दिस इज़ अ वेरी गुड प्रेजेंटेशन। आपने बहुत अच्छा प्रेजेंट किया और इसी तरह आप इसको प्रेजेंट करें और जो हमारी इंशाल्लाह कल क्लास होगी और उसके अंदर हम फर्दर भी बहुत इम्पोर्टेंट चीज़ें डिस्कस करेंगे और सैटरडे को मैं आप सबको ऑफ दे रही हूँ इन लिeu ऑफ द कॉन्फ्रेंस और इंशाल्लाह कल और हमारी फर्दर डिस्कशन हम करेंगे। थैंक यू वेरी मच एवरीवन।
Thank you, ma'am.
Thank you.
Thank you so much, Dr.